Hello, good evening, everyone, and you're welcome to today's webinar. Once again, my name is Pharmacist Innocent. We will be looking at Pharmacology and Physiology, SCM 315. And the course time is going to be 35 minutes. After that, we take our questions. So just a little recap on where we rounded up last week. I know last week we built a foundation about drugs in the body and drugs, and we gave example of the different types of drugs and the way the drugs are named. And we started with different route of administration. So today we'll be continuing. We've talked of administration of the drug. Right now we are going into the distribution of the drug. I know we started on with the distribution, so we are going into more detail of drug distribution. Once again, as I stated in our last class, we have different types of things that affect the distribution of drugs. We have aqueous solubility. Aqueous solubility talks about how soluble is the drug in liquids, in water, aqueous water from aqua. Then we talk about the blood flow to the direction where we want the drug to take effect. We also talked about plasma protein binding also impacts on the drug. You know, the albumin and other proteins that are circulating in the blood plasma, their binding also impacts on the drug. We talked about the lipid solubility of the drug, the tissue sequestration, metabolism and excretion, and volume distribution. So we are going to continue on those items enumerated one by one. So let's look at the aqueous solubility. We say that the aqueous solubility, how soluble the drug is in water, impacts on the drug distribution. Now, any drug that is highly soluble in water have difficulty crossing the cell membrane, and therefore it tend to remain in circulation. You know, the cell membrane or the cell membrane you have, they are more of lipid environment. And so any drug that is water soluble, we have problem crossing it. So what will happen is that drug will just keep circulating. It will not be well distributed at the targeted area. Okay, so they will be rapidly cleared from the system by the liver or kidney. So in practice, the truth is such drugs, they have little or no therapeutic effect because they've not gotten to where we want them to get. So we look at blood flow. At equilibrium, drugs are partitioned between plasma. We have plasma protein, and we have different tissue. At equilibrium, this is where the drugs are partitioned. So the rate of distribution to different tissue will be impacted on the blood flow through them. So if a tissue have a good blood flow going through it, blood supply, then there is more likelihood that that tissue is going to have more drug getting to that place. So we say, for example, the major organs like the muscle and the skin, they have a moderate supply, and the bones and adipose tissue have poor supply. So the bones have poor supply to them. Adipose tissue, that the tissues of the skin, the oily skin layers of the skin, they have poor supply. So for drugs you need to get to the bone, then there must be a specialized way of getting it there, or the drug may have very special qualities to penetrate the bone marrows. So major organs will definitely receive a higher concentration of the drug flowing through it, whereas it can be difficult to get drugs to well-perfused area. Okay. Now the brain has a good blood supply. Okay, but the CNS is a restricted area. CNS is restricted because they don't allow a lot of things get into that because of the sensitivity. Okay, so we talked about in the brain there's an anatomical barrier. Okay, rather than a combination of tight junction between the endothelial cell of the blood and of the brain capillaries and close associated glial cells with the outside of the capillary. So there's a way the blood is arranged. So the arrangement makes it difficult, okay, for the infusion of lipid soluble drug into the brain and the infusion of water soluble drug. They are almost impossible, okay, because of the way it's arranged. Okay, so if you need the blood to get to the brain again, then there may be a special way of you getting it to the brain, or the drug may have special qualities. But generally, most drugs find it difficult to get to the brain. Why? Because of what we call the blood-brain barrier. It's a restricted area, the blood-brain barrier. It doesn't allow, it's an anatomical barrier that doesn't allow things from the blood to enter the brain, okay, drugs from that place. So if the drug is lipid soluble, yes, it is more likely to penetrate. But again, it still finds it difficult. Then if it's water soluble, then it's almost impossible to get there. So another thing that affects distribution of drug is plasma protein binding. Now, if you look at the plasma, there are proteins that are circulating in the plasma. We have albumin and the other protein. Now, some of them have very high affinity. Okay, some drugs have very high affinity for this protein. So what's happening is that when you give a drug and it has a very high affinity to albumin, then albumin will bind to the drug. And when albumin binds to the drug, then it becomes very difficult for the drug to be distributed, do you get it, to the other areas that you want it to get to effect its therapeutic effect. Okay, so what happened is that this plasma binding protein like albumin, they will reduce active drug concentration and also reduce the ultimate response of the drug. Okay, so now it can even be an interaction. There can be a high interaction between albumin and some drugs. Okay, let's say example, aspirin have a high affinity for albumin. Now when you take warfarin, okay, warfarin is an anticoagulant. Warfarin also have a higher affinity for the plasma binding protein than aspirin. So what happens is that when you give warfarin will displace aspirin, and in such a case you can have a toxicity as a result of the product because of the displacement. Now we look at lipid solubility. Okay, one essential thing for a drug to enter the cell system is lipid solubility. Why? Because the cell system, you have the cells, the endothelial layer of the cells, you have lipid there. Okay, so if a drug is lipid soluble, then it can easily enter the cell. Okay, so that drug can be easily distributed around the body, except it has a high affinity to plasma protein. Okay, so again, elimination to these drugs, they are slow because clearance from plasma via the kidney remove only small part of the drug. So you find out that over a period of time, you see those lipid soluble drugs, may keep circulating in the body, leading to toxicity. So let's look at another factor that affect drug distribution. We have tissue sequestration. Now, sometimes some of these drugs may be sequestered or may bind to certain tissues. They can bind to some particular fat in the body. They can bind to a particular muscle in the body. Okay, so now sequestration in this way gives an apparent large volume of distribution, but what it means is that also small portion of that drug will be available to reach the site of action. And you know the relevance of administering a drug is it reaching to the desired site of action? So the impact of this is that it can create difficulty with the usage of certain drugs. So general anesthetics are highly lipid soluble. Okay, so for they're highly liquid soluble. So when you have fat people, okay, fat people have a lot of adipose tissue, a lot of fat. Okay, so since these drugs are highly lipid soluble, okay, so the drug have a high tendency of binding or sequestering into the adipose tissue. So the impact of that is that it will be hazardous. It's hazardous to people that are obese. Okay, so these are the things for when you are managing a patient, you have to take note of that. Okay, so another thing that they affect distribution is metabolism and excretion. Metabolism talks about breaking down the drug. Okay, excretion talks about eliminating it from the body. So the rate of metabolism will definitely affect distribution. If the metabolizing enzymes of the body of the particular drug, okay, if a particular drug have a high metabolic rate, okay, can easily go through phase 1 and phase 2 metabolism, then there's a high tendency that that drug will be broken down and it will not be available to be distributed to the tissues where it's expected to effect its therapeutic action. Okay, again, that may also impact toxicity. If the drug has a high, the excipients of the drugs or the metabolites are, they have a toxic effect. So what that will do is that if they are quickly broken down, a lot of them will be circulating, except they are quickly excreted, okay, through the kidney. If not, they will also cause toxicity. Volume of distribution is another thing that impacts drug distribution. So volume of distribution is just a concept that describes the body compartment in which the drug could be distributed. You know, the drug can be distributed into different compartments. Blood-brain barrier, it can be in the tissue, it can be in the plasma, it can be in the plasma binding protein. Okay, so we say that if a drug is water soluble, okay, if a drug is water soluble, it's highly likely to remain in the bloodstream. We've already mentioned it before that if a drug is water soluble, it will be difficult for it to enter the cell membranes. So what will happen is that it will keep on circulating in the blood. So its volume of distribution will relatively be small and equal to what? Blood volume. Similarly, acidic drugs, we have acidic drugs, they tend to bind to protein albumin, and therefore they will remain in circulation for long. So these are the 7 factors that impact drug distribution. So after the drug has been distributed, okay, remember we started from the different channels of administration. After administration, okay, we are looking at the blood, it goes through the GIT, depending on if it's going through the GIT or are you injecting the drug directly through the, if you injecting it through the the muscles, okay, or you are injecting it directly into the vein, or, you know, any model you use, So the next thing is the drug is distributed. So we are looking at the 7 factors. Now we want to talk about drug metabolism. This is very important, breaking down of the drug. Every drug is a compound chemical. Drugs are compound chemical. So when they enter the blood, the system, some are not as toxic as their metabolite. Okay, it's just like fuel. Okay, or it's just like fuel. Yes. So some activities we do in the earth, the fuel is not as toxic as what comes out of it. Okay, let's say, let me give an example. If you keep a jerrycan of fuel in the house and sleep off, it may not kill the person. But if you put a gen and the fuel is broken down, then it brings carbon monoxide, and somebody is sleeping in a room with carbon monoxide, the person may die, because the metabolite or the broken part of the fuel is more toxic than the normal fuel. Some drugs are that same way. So I want you to take note that immediately a drug enters the body, okay, they are treated as if they are toxic substance. So the body sees it as a toxic substance coming in. So there is need for it to what? Be broken down, to be detoxified. What the body does is to take it to a non-toxic status. Okay, so metabolism is the mechanism through which the body detoxify the drug. Okay, so after metabolism, what will happen is there should be elimination. Okay, naturally, if a toxin entered the body and is not detoxified and is not eliminated, it will be dangerous. Okay, so now what happens is that most of the drugs that we take, okay, they also, the body perceives them as toxic, so the body takes them through, okay, the metabolic process and the excretion process. Okay, now what happens is metabolism is the breaking down of the molecule of the drug by the action of what? Enzyme. There are different enzymes in the body, like the cytochrome P450. Those enzymes are responsible for breaking down these drugs that enter the body. Okay, so these have two important effects on the drug molecule. So when the drug molecule has entered the body and is broken down, there are two important effects. The drug is made more water soluble and therefore more easily to excrete, okay, by the kidney. You know, if the drug is not water soluble, it will be difficult for it to be excreted. So now what the enzyme does is to make them more water soluble. So the enzyme can break maybe a carbon chain and add OH to it to make it what? More soluble. You see how awesome God is. So the metabolites are usually less pharmacologically active than the parent drug. Most drugs, almost all drugs, okay, the metabolites are less pharmacologically active. So that means when they are water soluble, they are more likely to be excreted out of the body. Then the metabolites are less pharmacologically active to the parent drug. So what happens is this, that with metabolism, we expect drugs to be less active, okay, than how they were when they were introduced to the body. So that means if metabolism is very fast, then the therapeutic outcome we expect from the drug will not be reached. But now, in pharmacology, we've also navigated this, that in formulation of drugs, we have manufactured some drugs that the original drug, the product, is not pharmacologically active. Okay, it's not the metabolite. Okay, so these are some of the methods to navigate through these challenges. You know, the product is not active, then they are designed to remain inactive until they are metabolized by the body. Okay, so that some drugs are formulated in that way. Okay, because some drugs, it's difficult for the active drug to be formulated, so something is added onto them to be a prodrug. Okay, so that prodrug is like something that we enable it, you know, like a carrier system. So when the prodrug enters the system, is inactive, then when it's metabolized, the metabolized form is now active. Okay, now there are different phases of metabolism. There is the first phase, there's the second phase. Okay, now some drugs are completely inactivated in the first pass metabolism, whereas other drugs may not be completely inactivated in the first part metabolism. Okay, so even in the intestinal mucosa and different parts, you know, when you talk of metabolism, okay, it's not only in the liver. Some other tissues have enzymes within them that can break down some drug molecules, okay, that can break it down. Even in the intestinal mucosa, the lungs, and even the plasma, there are still some enzymes in those places that can break down drug molecule. So when you are formulating a drug, you need to put all those things into perspective. If you are formulating a drug and you want the drug to be active in the intestinal mucosa, now you have to find out, are there enzymes in the intestinal mucosa that can easily break down that drug and make it inactive? Those things are important. So what's metabolic reaction? Okay, there are two general types of metabolic reaction, metabolic breaking down. They are known as phase 1 and phase 2 reaction. So some drug will undergo both, others will undergo one. Okay, what will determine which of the metabolic process the drug will undergo is depending on the chemical nature of the drug. Okay, the chemical nature of the drug and the enzyme, okay, that is managing each phase of the metabolic process. It's also possible for a drug to be metabolized by either type of the reaction only. Okay, so take note of that. So we're going to look at the metabolism process. So if you look at my cursor here, you see the drug. So this is the drug. Okay, some drug may not be metabolized and they'll go to excretion. They'll just go to excretion. Some other drugs can pass through phase 1 metabolism, through phase 2 metabolism before they're excreted. Some other drugs can pass through only phase 1 metabolism before they're excreted. Some other drugs can pass through only phase 2 metabolism before they're excreted. As I mentioned earlier on, is dependent on the chemical nature or structure of the drug. Okay. So for the phase 1 is a biotransformation process. Okay. In that biotransformation process, the actual outcome or the intent of that process is to make the drug more water-soluble metabolite. Okay, so that can easily be excreted from the kidney. Okay, or it will go through phase 2, broken down before it's excreted. Okay, as I mentioned earlier on, the body sees that drug. Maybe you are having malaria, you take artemether lumefantrine. To you, you are taking drug to kill the protozoas, but to your body is seeing it that this is a toxin. So your body set out to destroy that toxin and make it more water soluble. So it will be looking at some different, it looks at the toxin, it looks at the structure, the enzymes decode the structure, the enzymes will now maybe integrate an oxygen in a place, or the enzyme will say, well, removing a carbon, a hydrogen, or add something else to make it more water soluble. You see how awesome God is. So oxidation. So these are the metabolic reaction, oxidative reaction. Okay, this is the most important and commonest type of metabolic reaction. Oxidation, from the word oxygen. It means adding oxygen to the drug molecule. So what happens is that the liver adds oxygen to the drug molecule, making it what? More water soluble. So the enzymes, there are enzymes that catabolize it, okay? the microsomal misfunctional oxidase system, or the cytochrome P450 enzyme family. This cytochrome P450 enzyme family is one of the most powerful enzyme family that are involved in drug metabolism. If you check most drugs that are taken in the body, most drugs that we take are metabolized by this guy, cytochrome P450. We respect them in pharmacology. So oxidative reaction takes place in many other tissues. So beyond the liver, it can take place, as I said, in the intestinal mucosa. It can take place, as I said, in the heart, in the lungs, in the plasma. So after oxidative reaction, the next thing is reduction. Reduction involves removal of oxygen or addition of hydrogen to the molecule. So the enzyme capable of catalyzing reduction reaction are found in many tissues, in your liver and in the intestinal bacteria. You know, in the intestine, there are bacteria. There are some very, very good bacteria in the intestine. That's why it's not advisable to just take antibiotics carelessly, okay? Because if you take antibiotics carelessly and excessively, you'll be destroying relevant bacteria in your body. So after the reduction, the next thing is hydrolysis. Hydrolysis means hydro from water, lysis breaking down. So involves splitting of the drug molecule by the addition of what? Water. So water is added and split it. So enzymes that are responsible for that, they are found in many parts of the tissue, particularly the small intestine. Okay, so this phase 1 reaction. So phase 2 reaction, in phase 2 reaction, the phase 1 metabolite, that's the outcome of the phase 1 reaction, okay? Phase 2 is trying to make it more hydrophilic, less toxic. So what it does is it conjugate it with what? Endogenous compound in the liver, okay? So this product has been hydrolyzed, this product has been oxidated, reduced, hydrolyzed. So the liver system in the phase 2 still want to make it less toxic, okay, and want to make it more hydrophilic. So it will do a conjugation, bring a compound in the liver. So this will help for renal excretion. Now, all that the liver want to do, all that the liver want to achieve is to make this drug to move out of the kidney easily, okay, because you know, without if something is not water soluble, it's difficult for it to go through the kidney, okay. So the most important conjugation reaction is with the glucuronic acid to form glucuronide. Other conjugation occurs with sulfate, acetyl, methyl, and glycine group. So these are the different compound groups in the body that the liver uses to conjugate the drug molecule in phase 2 reaction. So what are the factors that affect metabolism of drugs? Okay, enzyme induction, the kind of enzyme that is acting on the drug, okay, so we impact on it. Number 2, enzyme inhibition. We also have inhibition by enzyme system. So there are times enzyme will induce drug metabolism, there are other times they will induce drug inhibition. So the effect of inhibition can appear as soon as the inhibiting drug reaches a high enough concentration to compete with another drug for the same enzyme. Okay, so you may have a drug, you may have another drug, they are competing for the same enzyme. Okay, so one it will now be inhibited. So now when there is enzyme inhibition, it will focus on one drug and leave out the other. So these are examples of that. We have simeditine. Simeditine is used for the treating of ulcer. It can inhibit the metabolism of several potentially toxic drugs, such as phenytoin for epilepsy, warfarin for anticoagulation, okay, theophylline as a bronchodilator. So these are drug-drug interaction through the impact of enzyme. So when you are administering cimetidine, it's important to find out whether the person is on this drug. And interestingly, this other drug can be very toxic. Phenytoin, warfarin. Warfarin, if a patient is on warfarin and there is cimetidine inhibit the warfarin, the person can have bleeding. The person can be bleeding through the nose, bleeding through the eyes, bleeding through the ears. It can be that bad. Okay. So individual variation, there are individual variation. We are all different, okay? So there's something we call idiosyncrasies. We may have different outcome from the same drug based on individual peculiarities. Okay, so there are something we call gene polymorphism. Okay, some genes are different. Some enzymes, some people even the cytochrome P460 I'm talking about, which is the main enzyme for breaking down drug molecule in the liver. Some people are deficient of that enzyme. Some people have excessive of one enzyme. Some people have more of another enzyme. I give you an example. I met a lady, okay, that she doesn't take, if she takes anything protein, her body will be as if she just entered fire. Why? The enzyme that metabolizes protein is deficient in her body. So whenever she takes anything protein, she takes meat, she takes fish, she takes egg, whatever that has protein, she takes beans, you see her body bursting as if she entered fire. So individual variations are there. Okay, propranolol is a drug used in treating high blood pressure. We say about 8% of the general population are poor hydrolators of propranolol. Okay, so propranolol is extensively metabolized in those individuals. What will happen is what? Propranolol will show exaggerated and prolonged response. Okay, so is a drug for reducing blood pressure. So in those patients that are poor hydrolators, if you give them propranolol, if ordinarily the 10 milligram you gave them was supposed to reduce the blood pressure from 140 to 148 and 90 to 120 70, their own may reduce from 140 90 to, instead of 120 70, their own may reduce 150. Okay, why? They are poor hydrolators. Okay, another example is the metabolism of isoniazid, the drug they use in treating tuberculosis. Okay, so these are some of the examples of individual variation. Individual variation can impact on the metabolism of drugs. So that's why on the average, when a physician wants to treat a patient, it's good to ask a question about history, allergy, metabolism, and co. Age also can have effect on the way the drugs are metabolized, because liver function and hepatic enzyme, they are reduced at birth, especially children that they gave birth before 9 months. So those activities are reduced. So you need to take, if you don't take that into cognizance and you give the normal dose that you give a normal healthy child, you may see some unwanted side effects. It will seem as if the child took overdose. Okay, so from 4 weeks, there's a rapid development of life of these enzymes. Also, in the elderly, from 50 years and above, the metabolism of drug will start reducing. Why? Because of what? Reduction in hepatic enzyme. As people begin to age, a lot of things begin to wind down so that they prepare to go back to their maker. So even hepatic enzyme will reduce. So what happens is you may see more impact, more therapeutic effect, even to the extent of side effect of a normal drug. Okay, given a normal drug. So let's look at excretion. We've looked at administration. We've looked at distribution. We've looked at metabolism. We are looking at excretion of drugs. Okay, again, drugs are potentially toxic substance, and we have stated time and time again, and they must be eliminated by the body as quickly as possible. Even the best of your drug is a toxin. Okay, so this is often at odds with intended therapeutic use. Now, see what happened. You want this drug to achieve a metabolic effect or a therapeutic effect. So this patient had infection, okay, due to Salmonella typhi, and you gave this patient the drug. You want it to kill Salmonella typhi. But what your body is interested is to remove this, okay? So there is now need for a balance, okay? So now, the main route of excretion of drug and drug metabolites is through the kidney, You know, that's why if you see people that take some drug, when they urinate, you perceive it. Even you yourself that's listening to me, there are times you weren't feeling fine and you took drug. By the time you urinate, you'll be smelling that drug. Especially things like augmentin, ampiclos, you know, those ones can smell. In short, let me give you a gist. Previously, when it was difficult to manufacture augmentin, penicillin, what happened is this: when people are given before we have this industrial revolution that we can manufacture at large scale, when people are given penicillin, they will be told to bring their urine. So from that, their urine, those drug molecules will be extracted, filtered, cleansed, and the active metabolite will be extracted and used to produce another penicillin. Okay, so mainly through the kidney, that's where excretion takes place in the body, mainly through the kidney. Okay, so now in the kidney we have the nephron. Okay, the nephron, that's the smallest cells in the kidney. So this is the nephron. Okay, I want you to take note of this nephron. Take note of the structure, take note of how it's drawn. Okay, so this is nephron. So we have glomerular, the filtration, glomerular filtration. Now the glomerulus, okay, the kidney is adapted for the filtration of water and substance that are dissolved from the plasma. Okay, so when substance and water are substance are dissolved in the plasma, okay, the product, what the glomerulus does is to filter those substances, okay, because now your blood goes through the kidney, the plasma goes through the kidney. Remember that when we are talking about the other day, we are talking about oxygen. When you take oxygen, the blood carries it, okay, and take it. That's on the lungs. You have a high concentration of these blood capillaries so that they can lead to exchange of oxygen and CO2. So the same thing when you go to the kidney. Okay, so take note of the nephron, the structure of the nephron of the kidneys. Okay, so what the glomerulus does is to filter. Okay, now pressure is in the capillary of the glomerulus and it dissolves substance into the balnear. So you have the glomerulus, you have the balnear capsule. Okay, so the substance dissolve here, they filter through this place. Okay, so we say proteins are generally too large to be filtered in the glomerulus, and because of that, protein should not be in the urine. Whenever you notice protein in the urine, is an indication that there is problem with the kidney. Patients that have renal failure, okay, you see that you'll be seeing protein in the kidney. So another thing is drugs that are extensively bound to plasma protein. We've already mentioned that some drugs like binding to plasma protein. Okay, because of that, they will be filtered through the glomerulus very it will take time. Okay, so you read all these: tubular secretion, tubular reabsorption. Because of our time, let's look at other roles of a secretion. Okay, there's other roles of excretion. Most drugs are excreted through the kidney, but again, there are also other important there are also other routes of excretion of the drug. Example, through the nose. Example, through the skin. Example, through the breast milk. Example, through the rectum. Okay, so some drugs can be excreted in the breast milk. Okay, most drugs go through the breast milk, and that's why it's important for breastfeeding mothers. It's always important to take account of that. Okay, if a drug has a negative impact on children's growth, if a drug has teratogenic effect, then it should not be given to the mother, because the drug will come out of the breast milk and the child will take the drug. Okay, so other areas, okay, alcohol can come out from the nose. Okay, can be excreted through expired air. Okay, things like some drugs can come out of the poo-poo. Okay, so these are some of the areas that drugs can be excreted. So let's look at effect of drugs on body. Every drug we take has effect on the body. Now, yes, the intention of giving the drug is a good intention. I mean, the doctor that gave a patient Panadol has a good intention, but the drug has a potential to cause unwanted effect in the body. Some of these unwanted effects may be simple, some can be complex. Simple, let's say you took a drug and you have rashes. That's a simple unwanted effect. But some unwanted effect can be very heavy. Some can lead to blindness. Some, their skin will be as if they were put inside fire. Okay. So the study of the effects that drug has on the body and how they produce these effects the drug has on the body is called unwanted reaction. Hello? Okay, so let me take question now. Okay, okay. So so that's adverse effect. Let me just show you one adverse effect. Then we'll round up on that. Okay. So we'll be rounding up now. So this person took chloroquine, took a normal septrin. And you see, this normal septrin that you may have taken. Okay. So these are some of the unwanted effects. So thank you for joining the class. And we'll not be able to take questions today. Your assignment will get to you. And have a good night rest. And God bless you. Bye-bye. So please, if you have questions, you can just send it as a chat. Maybe I'll respond to it later. If you have questions, you can send it as a chat. Thank you everyone for attending this class. And God bless you. Bye-bye. So the questions are all here. Take note of the questions for your assignment. Thank you. Good night.